Good evening, Endo Summit Live, and welcome to the much anticipated evening on the appendix and endometriosis. We have a great panel for you this evening. We are introducing a new doctor to our crowd. She's new to us, but not new to medicine. Please welcome from Texas, Dr. Rachael Haverland. Dr. Rachael, can you introduce yourself, please?
Hey guys, it's such an honor to be here. I feel like I've been watching from afar for many, many years. But I'm Dr. Rachael Haverland. I am an endometriosis surgeon in Dallas, and I've been in practice there now for about 4 to 5 years.
Excellent. And we have joining us from California, Dr. Laurence Orbuch. Dr. Orbuch, can you introduce yourself? Dr. Orbuch, can you also tell us where you're practicing now? Because I had a patient this morning trying to reach you.
Hi. So I am currently practicing in Los Angeles. I used to be in New York until about 8-ish years ago. I was bicoastal for a while, but COVID kind of did away with the bicoastal practice. So I'm pretty much exclusively lately in California. I do still periodically operate in New York, but I can be reached through my Los Angeles office. And I'll share my contact information with you, Sally. But I too am an endometriosis surgeon. I've been in practice, I hate to say this now, for over 2 decades. Yeah, and I've like I think most of my other colleagues, do excision surgery, which is the preferred and the appropriate way to treat endometriosis. And I'm really looking forward to partake in this panel.
Excellent. And rounding out our panel is a general surgeon doing endometriosis excision. Please welcome Dr. Joe Raccuia. Do you want to introduce yourself, Dr. Joe?
Well, I'm Dr. Raccuia. My main area was liver and pancreas for many years, and then about 9 years ago, I've known Dr. Vidali for 20 years, and about 9 years ago we started working together. And I always like to say I'm his co-pilot, and we do everything from the diaphragm to the pee-pee. We're ready to do all kinds of different excisions, regardless of where they are. We even had a liver resection at one point. So it's been a very interesting experience, and I like to say I know more than most average gynecologists about this disease. So anyway, that's basically me.
I think this panel knows more about this disease than the average gynecologist combined, maybe about 30 average gynecologists combined.
Oh, and I've been doing this for almost 30 years, so don't feel too bad, Larry.
So what leads you to, first of all, let's talk about Dr. Haverland. Patient comes to you, and what might lead you to suspect the appendix could be involved? What are some of those symptoms?
Yeah, so the appendix in endometriosis is very, the symptoms can be really vast. They don't even have to have symptoms specifically of the appendix to have appendiceal endometriosis, which is what makes it so difficult. Endometriosis in general just doesn't fit in this little box. Not everybody has the same symptoms. Stage 1 endometriosis does not always correlate to symptoms. And I try to speak that all the time. Just because you end up having stage 2 or 3 endometriosis does not belittle your symptoms any more than somebody with stage 4, endometriosis. But, things that I look for are bowel symptoms. And we're going to get into this a little bit, kind of risk factors for having positive pathology on endometriosis. But, right lower quadrant pain, bowel symptoms, pain with defecation, blood in your stool, rectal spasms, rectal pain radiating, to your lower back, to your rectum. But again, you don't even have to have bowel symptoms or right lower quadrant pain to ultimately have pathology positive endometriosis on the appendix, which is another reason why it's so important to have specialists knowing what they're doing when they're in there, managing you surgically so that you get the best outcomes.
Dr. Orbuch, are you doing before surgery any kind of imaging that's valuable?
So I think, sometimes, but not very frequently, incidentally, when you do an MRI on some of these patients, you may see some pathology or you may see some deviation in the normal anatomical location of structures like the appendix. Um, but as a rule, not really. I think, the majority of patients don't really have any specific symptoms related to appendiceal involvement. And it's generally an incidental finding. I published a paper about 2 years ago about my findings regarding appendiceal involvement. And it was pretty much in line with several other studies that were done. I found 18% of my patients had endo in the appendix, but overall, it was roughly 42% abnormalities, ranging from endo to carcinoid tumors to primary, low-grade malignancies of the appendix, to chronic appendicitis, acute appendicitis, and also things like fibrous obliteration, which is, people say non-specific when you talk to pathologists, but it's very common in patients with endometriosis where there's fibrous obliteration of the lumen of the appendix. But one of the key takeaways that from what we found was that you can't gauge by the external appearance of the appendix whether it's abnormal, because I've had more than my share of patients where it looks normal, you take it out and you get the pathology report back and it's grossly abnormal, or it looks normal from the outside, but then you actually physically grab it and you squeeze it and it doesn't compress. It's kind of rubbery and hard. So something's in there. It could be something as little as like a fecalith, or it could be some serious pathology. But if you don't look, you don't find. And I think when you have the incidence of involvement in pathology in the appendix approaching nearly half of the patients you're operating on, many of us have adopted a routine policy of taking the appendix out at the time of surgery. And then, when you factor in other features like, patients with endometriomas have a much higher incidence of involvement of the appendix. Patients with adhesions, it may look normal, but I had a patient not too long ago where literally the appendix was tethered to the liver by this thick band of adhesions. Like literally I snipped the adhesion and it went shooting back like a boomerang down into the pelvis. So it's very, to me, it's a no-brainer, to deal with it, because it's a potential continued source of pain and a potential source of pathology of various different types.
Excellent. So, Dr. Joe, you are a general surgeon. I'm sure you can think back long enough to remember dealing with appendix before you knew anything about endometriosis, like, when you were 40, 50 years ago. So, what is the difference between what you originally learned about when to take an appendix and what you practice today?
All right, so I have, like Larry, we looked initially. I'm just talking about endo at this point, okay? Because it's a transformation to a disease, a procedure transformed into a disease, okay? In the sense that when we looked at the time about 263 patients early on, and we had 14%, which is almost equal to your 18% incidence. Having said that, there's more involved than anticipating appendiceal involvement. And I have some hard indications for doing an appendix and some soft indications. The hard indication is, like Larry said, there's a significant percentage of these patients that have endo involvement, period. Having said that, a very hard indication, if you're dealing with an under 30-year-old patient, and this is a general surgery dictum that has chronic pelvic pain, it's obligatory, unless there's some other circumstances involved, to remove the appendix, because later on down the line, you don't want that patient ending up in some ER somewhere with a misdiagnosed appendicitis when something else is going on. So they can actually say, no, my appendix is out. And then we're moving to another a list of rule out diagnoses. The other thing is cecal involvement. And when that happens, we end up doing, a cecectomy with it. Another area, which I'm not going to go into here, is when the ileocecal valve is involved, because that becomes a very more complicated issue. And I think that's for another discussion. Having said that, my soft indications are patients that have an appendix, like Larry had his up in the liver. When you open up, before you go into Nellenberg, if your appendix is deep into the pelvis, I would urge people to take those out, because those appendicitis, or retrocecal, because those appendices are later on down the line going to be much more difficult to treat and diagnose. The other thing is, in terms of the indications, I think they're softer for older and fertility patients. And I'm talking about those patients that have not tons of disease, because it's a no-brainer. If you're full of endo, I think the appendix should probably come out. The other thing is diaphragm involvement is a good marker for more diffuse involvement. I think you really have to search the abdomen and really look at the appendix. The other soft indication, and I think you said that, is about adhesions and/or abdominal wall proximity. But when you put the age factor in, from our own, general surgical dictum, is that if you're under 30, absolutely 100%. I think we consent almost all the patients for appendectomy. I think presently we're doing more than we did initially when we started this, considering that our indications, hard and soft, have expanded. But it's something that I think from an endometriosis standpoint, not only involved with endometriosis, there are criteria to remove these prophylactically.
Yeah, so Dr. Chung has popped in. He fed me some literature earlier before the webinar began, and there is some discussion in the literature, and now there's going to be discussion on the Endometriosis Summit about how we feel about it, that to find an appendix that's positive for appendix endometriosis, you have to take between 100 and 1,000 and appendices, however it works.
Appendices, you got it.
And I want to open this I want to open the panel up for discussion on this. We're going to start with you, Dr. Haverland. What do you think about that? And then we're going to go to Dr. Chung. We're going to, work it out.
Hey, Dr. Chung, glad you could join us. Even in especially compared to you guys, my short experience so far with endometriosis, I have found a much higher number. And when I did my literature review, stage 1 endometriosis about 2 to 4%, but with stage 3 and stage 4 endometriosis, especially with deep infiltrating disease, and I found this in my own practice as well, at least a third of those are going to have positive endometriosis, like pathology positive. And the studies that I found that, similar to what you guys have, you actually have really high numbers similar to what this, the more high quality studies I've been looking at, but they're up to 39, 38% for stage 4 endometriosis, which I would say probably a third of mine with deep infiltrating disease, especially right-sided. So deep infiltrating on the right, endometrioma on the right, adhesions with the appendix, I'm getting about a third. And it's not always hard and fast. 1 month, maybe I'll have, 10%, and then the next month I'll have 40%. But with the higher stage endometriosis, I have been finding path positive. And I think it also depends on your pathologist knowing what they're looking for. So that may be a little bit of the discrepancy as well.
Dr. Chung, your feelings on if that literature of 100 to 1,000 to get one that's positive is correct? Like, share your opinion on that.
Well, you look at all these studies published, and they are pretty good review. If you talk about appendix endometriosis, ranges from 4 in 1,000 to as high as 7% in those patients with endometriosis. Now, I don't dispute that when you have stage 4 endometriosis, the chances of appendix endometriosis is higher. But the question is, yeah, when you find patient endometriosis, especially with chronic pelvic pain, I don't have any dispute to remove the appendix. Of course, you need to tell the patient ahead of time, this is what you're going to do, just so that you can avoid another surgery, patient end up in the emergency room, another surgeon go in there and remove the appendix. But the questions I want to raise to the expert is, right lower quadrant pain, you assume that is endometriosis on the appendix, or is it something else? And that's the questions. And the diagnosis, appendiceal endometriosis, when you find it's on there, but that doesn't necessarily mean that the pain was from the appendix. So I'm just opening up that for discussion. Yeah, if everybody goes in and take out appendix, you almost have to take out so many to get a positive value. But of course, when we're dealing with stage 3, 4, that's a different story. Nobody fought you for removing the appendix at those situations.
What role, and we're going to have Dr. Moling on, who's doing research in the microbiome, but what role, Dr. Orbuch, does the appendix play, if any, particularly in the microbiome and the immune system?
Yeah, so there's a lot of theories that are thrown out around. I haven't seen any compelling data to really show any significant validity to that theory. I think, just as a side point to what Dr. Chung was saying, I don't recall ever having a case where the only pathology was in the appendix. So I agree with you. I don't think that the source of the pain is necessarily from the appendix when patients have right lower quadrant pain, but it's residual disease that you're leaving behind if you don't address it. I think as far as the statistics go, like my numbers, my 18% is in a pool of somewhere in the neighborhood of about 300 patients. It also, I think, depends on your practice. Like many of you, I end up getting patients who are not first-time surgical, patients. They're patients who have had multiple prior surgeries, and they're more advanced, deep invasive disease and with a lot of pathology. And so that may skew the data as opposed to an all-comer kind of practice where with first-time presenters, where you're getting a quote unquote virgin belly, to operate on. So that, I think, steers the numbers a little bit higher. But regarding your question, I don't know of any definitive study or data that's out there that would back up, the retention of the appendix because of some beneficial sort of a factor like that you're bringing up.
Dr. Joe, do you feel that there's any role of the appendix?
You're talking about from a vestigial standpoint in evolution?
Yeah, just from an
Yeah, well,
existence.
it's a lymphoid rest, like the spleen. It's always been known to do that. It probably doesn't have the effect after birth that one would think, and that's why organs like the appendix are can be removed, like the spleen, where these are vestigial organs that produce lymph tissue, to the fetus. But having said that, I just want to address one thing. This 1 in 1,000, I'd love to see this paper, because Larry, our data was based on 263 patients. We had 14% positivity rate. You had almost 300. Granted, these are centers for this type of disease, and maybe that might skew the results a little bit. But regardless of that, there are clinical indications to remove appendix that don't necessarily involve endometriosis.
Mhm.
And I, bring this back to the young under 30 chronic pain patients. It is obligatory, in my view, to do an appendectomy. In terms of the depth of the disease, I never liked this staging thing, and I'm not a gynecologist, but I never liked this thing because they do it by depth. And really, it should be done anatomically in terms of the locations of the disease. The depth is irrelevant. You know, you guys can pull these things out no matter how deep they are. It's about the location of the disease, and you can have which I hate, the staging, stage 1, that can be diffuse. Chances are that a patient, especially if they have chronic pain, should have their appendix removed. Having said that, I think again, there's the hard and the soft criteria in my mind, and you know, looking at other people's data, I would just say that, you know, concurrently with Larry, you know, and we have now almost 3,000 cases. We're not looking at that particular criteria anymore, but I will guarantee you it's probably even higher than, you know, Larry's 18% if you're going to just look at endometriosis involvement. But as I said, I'll reiterate, it goes beyond that, because there's a clinical spectrum where you have a chronic pain patient that you want to obviate the risk of them having something untoward, you know, untoward doing something, you know, maybe where the patient is misdiagnosed later on, God forbid something comes back, something happens. So that's my take on it as a, you know, a non-gynecologic surgeon.
So a few of you have mentioned the presence of endometrioma and appendix. What is that connection, Dr. Haverland?
Well, I think it just has to do with, you know, kind of what we were talking about, the depth of the disease. And I'm not sure there's an actual link. Like it could be some lymph spread. It may just be sheer location of, especially on that right side. But I think in endometrioma, we all know if we see an endometrion imaging, they never just have an endometrioma. It's usually indicative of much more aggressive disease or more widespread disease. And so I think when it gets to the point where it's formed this chocolate cyst, then that's just another indication that the disease is probably more widespread, more in depth, and that may be why we're more likely to see path positive on appendixes.
Yeah, and there's a physiologic theorem as to how any fluid in the abdomen and pelvis circulates, and it goes clockwise from left to right. So things that are, you know, like an like let's say a leaky or ruptured endometrioma, it's going to go to the right lower quadrant, even if it's on the left side. Right. So generally, it's when there's an endometrioma that's had some leakage or outright rupture, then, you know, it's much more likely to be on the appendix. It's a lot of times also going to be on the rectum and the sigmoid and small bowel, and that's why it really requires careful inspection to make sure that you get all the disease that's been spread via direct contact like that.
Yes, so let's talk a little bit about how might the appendix cause groin pain, because we're going to get into it. Also might not be causing groin pain as well. So who wants to take a stab at how the appendix might be contributing to that groin?
Can I start? And I'll tell you why. You know, in Europe, in the pathology books forever, probably for the last 50 to 60 years, there was an entity that the American doctors, I still think they refuse to recognize the issue of chronic appendicitis. And there's a ton of studies in Europe over the years where they actually treated appendicitis just with antibiotics and they got better. Huge study in Denmark way back when. So, you know, the issue is you don't have to have overt and like appendicitis, I use the word hepatitis, the same thing. All it means is inflammation of the organ. It doesn't denote the pathology involved in terms of, you know, whether it's endometriosis, whether it's a carcinoid, whether it's a pure chronic appendicitis. So the idea that appendicitis is an entity only related to what we know as someone goes in right lower quadrant pain, they go to the hospital, they get a laparoscopic appendectomy, they feel better, they go home. There are other entities involved where it can actually be related to the chronic pain. And if not, as I said before, I want to underline this, younger patients, please feel very free to remove their appendices.
Yes.
Yeah.
Okay. Dr.
Yeah,
go ahead.
No, I'll just throw in my 2 cents. You know, there's the thing that most practitioners fail to grasp is the whole central nervous system upregulation in these endo patients, and the chronic and the chronic nature of the condition and what it does over time. So you can have all these seemingly unrelated symptoms that people never kind of put together. The puzzle doesn't kind of fit for them. And over time, you get these either some local, but a lot of times distant pain symptoms that don't seem to fit. And that's why it's important not to ignore them, and also not to minimize it, because the tendency, and I've had many patients who've told me, like, I've had symptom X, Y, and Z. My doctor told me like half of these things are in my head. They don't understand why, and blah blah blah. But in reality, the central nervous system crosstalk between nerves and the communication, centrally to the peripheral nerves, and how your entire system is affected, can impact pain being triggered in various different places. With the appendix, which I think Joe was saying before, when you see an appendix like socked in the pelvis, there's usually something going on, either direct contact with, or adhesions, or the endometrioma with an appendix stuck to it, and then you have the local nerves that are being triggered, which will then give you pain. So a lot of times, and I'm sure all of you experience this, where patients are convinced, and like, I guarantee you, when you get in there, you're going to find all my diseases on my right side. And I get in there, the right side is completely clean, and everything's on the left side. Endometrioma, sigmoid colon, sidewall, ureter, everything is just one mass. And then you show them the pictures, and they're like, that doesn't make any sense. I'm like, but this is why. So that's something that you really have to keep in mind.
Dr. Chung, how might the appendix generate pain? And what are other structures that can generate pain in that area?
Well, structures, muscles, nerves, ovary, appendix, they all could generate pain. And just use appendicitis as an example. Start at right lower quadrant, McBurney's point, then travel and get down to the right lower quadrant. Well, that's infectious appendicitis. So that's where it starts. Now, right lower quadrant pain can be so many different diagnoses. You can name it. When we were in medical school, how many diagnoses are there for right lower quadrant pain? That goes up to the gallbladder, mesentery, anitis, and just a gazillion number of those right lower quadrant pain. But in my personal experience, when you examine a patient, if a patient tell me she had right lower quadrant pain, and invariably I could reproduce the right lower quadrant pain in a pelvic examination without touching the abdomen. And you just have to be, keep your mind open that the right lower quadrant pain, not necessarily is right lower quadrant. It could be a referral, could even be the bladder, pelvic floor muscles, and the pudendal nerves, or ilioinguinal nerves, or the endometriosis on the C-sections, incisions. So the questions I have is this: when a patient right lower quadrant pain, when you do surgery, are you going to remove the appendix when it's clean? I suppose nobody's going to blame you for it when you remove it, which is safe. The study recently published in June. Yes.
Wait, let's stop and ask our panel. Let's everybody comment. We'll start with you, Dr. Haverland. Are you going to remove the appendix if it looks clean?
100%. Because we do you want me to elaborate or no?
Yes, go ahead.
Yeah, we have studies, that are showing, just like Larry was saying, normal appearing appendix come back pathology positive. So you can't always go with how it looks. The easy deep infiltrating disease on the appendix, that's a shoe-in. But especially young, an opportunistic appendectomy for sure. And then if that's the location of their pain, there's even some case studies of women with endometriosis not found elsewhere in the pelvis, but found in the appendix. So I think you just keep all that in mind.
Dr. Joe, normal appearing appendix, you gonna take it or not?
Most of the time, I would say the lion's share of the time, yes. But as I told you before, the criteria that we use, I think on a fertility patient that has minimal disease, an elderly fertility patient, somebody over 30, and I say elderly, but having said that, having said that, I think you can lean more towards occasionally not taking it. I say occasionally not. Because I agree with Rachel, and I think if you think of, we have a dictum in surgery. If you think about it, do it, because you're going to kick yourself afterwards. We do this safely. We've had really bad experiences doing, appendectomies. It's a fairly simple operation with a very low morbidity, and in fact, you're dealing with a patient that's having chronic pain. And I'll bring up, what was said before about the nerve involvement. Let's not forget, and I'm not a gynecologist, but the hypogastric nerve. How many patients have we seen relieved in the recovery room when they say, "Oh my God, that pain is gone," and that's after surgery with incisions and things like that. So, I would be remiss to say there is not some type of involvement, neurologic involvement, even on an appendix that might not look, diseased on the surface.
Dr. Orbuch, appendix appears normal. You taking it or not taking it?
I generally take them. The only time that I don't is if, you have the occasional patient who prefers you don't do the appendectomy unless it looks abnormal. But I find that most of the time when you have a very lengthy discussion with patients and you present the data to them and what the risks are and how, what Rachel was referring to, like what we discussed earlier, is that the appearance doesn't mean anything. But I would say, if my preference is to remove it.
Okay, Dr. Chung, back to you. Normal looking normal looking appendix. You taking it or you not taking it?
I used to take them all, but then I just take a step back, just like Dr. Joe. But now I try to remove and take care of the pain first. So if they have right lower quadrant pain, I pretty much could map them out and take away the pain before the surgery. So if I know that the pain's gone, then I don't necessarily take the appendix if everything else is clean. But then, another thing is I don't want the patient going to the operating room the second time because another surgeon need to take out appendix in a different time. So it's safe to remove it. As I said, it's very safe to remove it. And especially for the young patients. So my answer to you is I don't necessarily take them now. I used to, and I just take a step back and just see where we're going with that. Maybe the second time I'll do it.
Okay, so I used to do a lot of work in groin pain, and I did a ton of work in endometriosis and the cross section of both of them. And I want to talk about the patient that I used to see quite often, had excision and had lower right quadrant pain. We're not talking about left, right quadrant pain prior to excision, kept complaining, I have this pain, I have this pain. Doctor takes the appendix. Patient continues to have pain, for some reason goes back to the surgeon. Surgeon takes the ovary, does another surgery, takes the ovary, which you should only know how I feel about that. Pain continues. Let's talk about that case, because I saw that case all the time. We put up an Instagram today. We have about 10 comments on that, almost that case exactly. They took my ovary, they took the appendix, but the pain is still there. Who wants to talk about the differential that they may see?
I want to start. Go on.
No, I was just thinking about all the differential diagnosis in medical school. You have it. You're the surgeon.
So I mean, when you look at the appendix and you have all these differential criteria, I think one must remember that these patients have chronic pelvic pain. That's the first and foremost. And in terms of what you described, Sally, all due respect to these patients, you remove you're talking about a patient, removed it, they go back, then the doctor takes out the ovary. These are, and I'm going to say this, these are doctors that don't understand the disease, because I will guarantee you, in our experience, that those particular patients, when the doctor says, oh, there's nothing there, and they had a recent laparoscopy or robotic surgery, and we find tons of disease. So remember, you can look at a pelvis that has some adhesions, and then when you start really taking those adhesions down, you realize that they're loaded with endometriosis. So going by a description of, I'm going to say a non-expert endometriosis surgeon, those are those patients who get lost into the, wastebasket category of the generalist who, they keep going from doctor to doctor until they get to somebody who has dedicated their practice to this disease. And very similar, and I've said this before, I've done over 500 retroperitoneal sarcomas. And although I can tell you that the numbers were low, I had 3 patients after massive operations that within 3 to 4 weeks ended up in another hospital with appendicitis. And that was a horrific situation. Now, anecdotally, I'm just saying this anecdotally, and I wouldn't want anybody to practice like that. The however is those things stick in your mind. And as you get, the younger the patient, the longer they're going to have. As one of my mentors says, anticipate your younger patients especially will need more surgery during their life for whatever diagnosis. Forget endometriosis. So I
think one thing in endometriosis, we need to begin, and maybe not the 4 of you here tonight, but we need to anticipate that younger patients are going to live a long time. And we can't be robbing and drying their systems out of estrogen when now we're seeing the connection of dryness and lack of estrogen to Alzheimer's. And so what Dr. Joe is saying is anticipate what this person's life is going to be like. But listen, I'll tell you the truth. I practiced a long time. I saw plenty of decent excisionists. Some who call themselves, maybe I'm not talking about Dr. Vidali, but others in New York who call themselves the tops, and the ovary would be gone and the appendix would be gone and the pain would remain. And here is my list of differential. I would look at that pudendal nerve. I would look at that ilioinguinal nerve. I would look at myofascial restrictions in the abdomen. I would look at what's going on with the bladder. I would add what's going on with the hip. And I would add also what's going on with the pubic bone itself. How do you guys, Dr. Haverland, you're in a multidisciplinary practice. How would you approach some of those things?
Yeah. And, we get this. We get this even with good excision surgeons. I mean, I would like to say all of my patients get 100% improvement after surgery, but that's why you have to have this multidisciplinary approach. And one surgeon or one physician, one provider can't do it all. Physical therapist can't do it all. Physiatrists can't do it all. You need this multidisciplinary approach because when you've had pain for so long, there's not going to be one entity that erases it all immediately. Sometimes, and that's awesome when it happens, but most of the time you need this multidisciplinary. So prehab. So we call it prehab, but first of all, in an ideal world, if everybody had, all of the time in the world and finances weren't an issue, we would have them undergo physical therapy before surgery so that they can help manage their pain, their symptoms afterwards, learn relaxation techniques afterwards. And then all of my patients actually do see physiatry post-op. So at 4 to 6 weeks post-op, they're being evaluated, their pelvic floor, their nerves, the central sensitization of pain, like Dr. Orbuch was talking about. I mean, from the brain to the nerves specifically, whether it's, an SSRI helping kind of reshape those nerves or an ultrasound guided nerve injection to help, physically target the nerves that are there, suppositories, vaginal suppositories, gabapentin, Valium, an NSAID. It all depends on your symptoms and kind of how we're treating you. This is not a one size fits all. Not everybody needs the exact same, treatment. You can't treat everybody the same because obviously everybody has different symptoms and, it has kind of, it's important to have an individualized approach, but, and then physical therapy afterwards. I usually say within the first 6 to 9 months, maybe a year after surgery is when you're going to have the most improvement in your symptoms. And that's when you really need to put forth the effort, make time, make this a priority. Because if you put in the time after surgery, after we remove the underlying disease, I think that's when we have the best outcomes. And again, I'm relatively new, so I realize I'm bright-eyed and bushy-tailed, and I still like to think that everybody has this, positive outcome, but I believe it. It's some people have it easier than others, but I do think a multidisciplinary approach gives the best outcomes.
And I agree 100%. And I've been doing this for 20 years. And I just, it really, the best outcomes are when you educate the patient, then you get then you get better compliance. When you explain to them why they're having the different types of pain that they're experiencing and what you're going to do to address them, then you're more likely to have a partner in the process rather than, a passive participant. And I think the problem, and I see this many times, I see patients who have had decent surgery and no one has ever addressed any of these other pain generators. They haven't addressed the specific nerve pains, be it from whichever nerve is being impacted. They haven't treated them with trigger point injections, with medication, oral medications, pain, vaginal and rectal suppositories, and the pelvic PT to release all these trigger points. And it doesn't. And I also, especially when I have time, when patients who are not going to have surgery like right away, I do the prehab always. And patients are like, well, I'm going to have my surgery in 4 weeks. Why should I start? I'm like, get plugged in, start doing PT. The majority of people, even if it's a slight improvement, psychologically it means a lot, because then you see, I think, I'm on the right path, and it changes their perspective and it changes their expectation, and then they work toward the resolution. And that's the only way that you get to what I call the best possible place that you can be, is by doing that. Otherwise, you hit that glass ceiling of improvement, because surgery can only do so much. I find it works more globally in younger patients, like in my teen and early 20s patients who have not been experiencing all these symptoms for so many years, that their central nervous system is so upregulated. Mm-hmm. But the majority of people do need that multidisciplinary approach to really address everything and to really wind everything down and downregulate all these different pain generators.
Dr. Chung, when you're dealing with a person that might have that pain from another source, what do you do? Appendix first, or you deal with the other generators first?
Well,
why?
I've done that for the last 30 years, and I usually approach it I just try to desensitize at the entire pelvis. So in my data, and we submit the publications, finally, I could downregulate 85% of the patient, and with the visual analog score down 85% of the pain before I even take them into surgery. Because the two biggest generators that I see in the pelvis is, one is the bladder, the other is muscles and nerves. And the muscles and nerves are the pudendal nerve, which control the entire levator muscles. So regardless, those two are sensitized, whether that is a secondary sensitization or central. So I like to desensitize it first before I take them into surgery. And there are many times that the patient's pain was 100% gone before I even do the surgery. And I find some endometriosis. But if I don't remove them, those endometriosis is like fanning the fire. Then the pain would come back maybe in 6 months, a year. So I would remove them. And invariably, they are just superficial endometriosis. But remember, the pelvic peritoneum, we have these inferior hypogastric nerves, like the urosacral ligament, If any of those endometriosis implants is near that nerve, you are likely to have some bladder symptom, urinary symptom, and many times it could be the bowel. So what I view is I work on the bladder, I work on the pudendal nerve. I would do those before I even send them to PT. Because after I'm done with that, the patient's, oh, the pain's gone. Do I have to go? Well, it's up to you. And but the surgery wise, some of those I say, well, why don't we just watch it? If it comes back, we'll do surgery. And if the patient, after I downregulated with the pain decreased by 70 or 80%, and I just have these 20, 30% of the pain I could not get to, and I found endometriosis in the peritoneum a lot on those patients. It's just those I could not get rid of on the desensitization method. And that's what I usually see. And for those patients, when I could not get the pain downregulated 100%, those are the muscle area that I could not reach with my examination, and PT Botox work on some of them.
So we're
But
going to talk a
tell them-
lot about that next week. I want to have like a weird shift of gears, so to speak. So Dr. DeLumba is not here because the Pittsburgh Steelers game was just wrapping up as we were starting. But this is something he's been very vocal about. Dr. Joe will have one opinion. I wonder what it is like for the doctors working in hospitals and who need general surgeons or a multidisciplinary surgical team to take the appendix for them, and what insurance is like and what the hospital is like. Because I've had doctors, Dr. DeLumba being one of them, say their hospitals, you know, wanted to put an end to it. And it was really very difficult at that point to run cases. Dr. Haverland, what's the environment like in your OR? This was a hot topic at AAGL also.
Yeah. Yeah, you know, I think that gynecologists, surgical gynecologists, people that have, you know, that are well trained, that have had additional surgical experience, there's no reason why you shouldn't be able to do an opportunistic appendectomy or an appendectomy at the time of an endometriosis surgery. There's plenty of literature showing the benefits, showing the correlation with endometriosis on the appendix. There's also plenty of studies show that you know, there's not really much increased risk of surgery, if any. Even though you're working on the bowel, as long as you know your antibiotic coverage, there's not increased risk. I am lucky. I was trained very well. I was trained in, you know, appendectomy, so I'm able to do it at my hospital without any issues. Now, Dr. Joe has a lot more, you know, experience than I do. So if there's a complex, you know, case where you have to do a cecectomy, or if it's, you know, there's certainly times when you do need to call in rather a colorectal surgeon or a general surgeon. But for routine appendectomies, I'm able to do them all myself. And I feel very lucky to be able to do that.
We definitely have seen more than one MIGs working at hospitals that the hospital doesn't, I hate to be blunt like this, they don't want to lose the revenue on their surgeon doing it, and they don't let the GYN do it. Does anyone want to comment on that? I really missed how could the Pittsburgh Steelers be losing while I want to have this conversation?
Yeah.
Not here in
Yeah.
West Virginia, Ohio.
Yeah.
So
It's an issue that's come up. Dr. Joe, in your hospital, now you're in almost every single case. Do you have any issues with reimbursement and having multidisciplinary surgeons in the room at the same time?
Absolutely no issue. And you know, I'll go a step further. You know, you can teach a very competent gynecologist to do an operation. However, you know, all due respect to everybody here, our approach has been very different. You know, we've had the multidisciplinary approach, surgical, inside the operating room. So everyone's available during every case to do what needs to be done. So it doesn't become an issue of, you know, can you do it? Do you get paid? You know, we think about the payment afterwards, first of all, too. Let's face it. I mean, you know, you're here to, you know, take care of people. And at the end of the day, everything comes out good. Having said that, when the bowel work becomes more complex, my recommendation to any of the gynecologic surgeons is you can do, and any surgeon, you can do anything 95% of the time and get away with it. That 5%, when you get into a problem, and I'm talking, medical legally, you're going to want to have that guy has your back, because you basically are transferring all of the responsibility to that other surgeon, which is fine. And that's what that surgeon does. So, our take on this is a little different than most of the units that do this surgery. And I think that's a really important factor. And the more complicated the excision becomes, I think you'd be remiss not to have somebody who, has got your back. And it has nothing to do with surgical capabilities or techniques or abilities. It has to do more with the environment that we work in. So that's my, take on this.
I agree with that 100%. Always having somebody that you can call, somebody next door, it makes my world a lot easier. To know that there's a urologist, general surgeon, colorectal, next door that can come help me if I need to. But yeah, I agree with what you're saying 100%.
Dr. Orbuch.
As do I. I think it's foolish not to be what I call over-prepared, because you hear many disasters story of people who go to the OR, have not properly worked the patient up, and they get into a messy situation that they're incapable of handling, and there's no one around to help them. And that's the worst thing you can do. And that's why it's best, it's best diplomatically to always keep your channels open with all different subspecialties, because you call them, they call you. It creates the best environment for patients, because then they have the best possible care available. Granted, in a smaller, rural hospital, you don't have that luxury. I also am trained and capable of and credentialed to do appendectomies myself. And also, the reality, going back to what I said earlier, is that most of us get a lot of the more difficult cases. So either in advance there's major bowel involvement, or it's going to be a really difficult case. Like I did a case a few weeks ago where a woman had 3 prior surgeries. One, she had a sneak and peek, like laparoscopy, a peek and shriek, and then someone did 2 laparotomies. They couldn't do anything because I read the operative reports: frozen pelvis, unable to identify any structure. And so I went in there robotically. Granted, it took me 4 hours to undo she had like real stage 4 endo, where everything was just matted into the pelvis and into the sidewalls, into the bladder, into the rectum. What do I do if I didn't have a colorectal person with me? Then I'd be like scurrying about trying to find someone. So, it really makes a difference. And it's the difference between patient safety and outcome, and also being able to actually get the surgery done. So I think it's really, if you're going to be doing these types of surgeries, you really need to be prepared.
Can I add one thing too? Just what you said, Larry, that kind of case, but all cases, and this is something early on that nobody was doing. It all starts with the bowel prep. I mean,
yeah. Oh, absolutely.
You can't do these cases without having a bowel prep, because getting into a prep bowel is completely different than getting into an unprepped bowel. Regardless,
100%.
and it's
is that debatable now?
No, we're going to hold that for the summit.
Yeah.
No debate at that 8:54. No debate.
I'm
absolutely not debatable.
I'm with Joe. I bowel prep everybody.
As you should.
Without getting into the debate, do you bowel prep everybody, Dr. Chung?
No.
No. Do you bowel prep at all anymore?
No.
I remember we used to work with a pelvic.
Well, maybe I'll give them a fleet enema so that I don't have to deal with a lot of those things there.
You remember Dr. Nieves? He just stopped with the bowel prep when he started to look at the research.
Oh, we used to. All these gold lighty solution. So much back in those days.
That research is on hysterectomies, excuse me, though. It's on, extensive intricate, complex pelvic surgery. Though that all that data comes from hysterectomies. It has nothing to do with endometriosis.
No, even though many of our colleagues, they don't, and even though they want to work on the bowel, well, sometimes, I mean, it's debatable to certain of us that work on the bowel, and we would argue if you have all the stool, liquid stool in the bowel, when you make a hole in it, it spills much quicker than some solid stool. So that's just one of those discussions we always had in our meeting.
Yeah, we're gonna have a bigger discussion on
Yeah,
that.
that'd be a big discussion.
Yeah, we gotta get Abhishek and Gabby
Yeah.
in here for that discussion. It'll be good. So the Endometriosis Summit is coming up March 8th through the 10th in Orlando, Florida, and it does have a link that is available virtually. I do want to restate that we have 4 CME approved for our lab. If you are an MD out there looking for CME and endometriosis, then the Endometriosis Summit is the place to do that. But before we wrap up, you are all faculty at the Endo Summit, and we ask everybody to leave with what they're looking forward to the most at the summit. Dr. Haverland, it's going to be your very first summit. What are you looking forward to the most? Now, Dr. Haverland comes from the pelvic rehabilitation medicine team. They sponsor the pool party, but they come with 15 very fun people. So
That's nice.
what are you looking forward to the most about the summit?
Yeah, well, one thing that I think is so amazing about the summit is that you get this physician-patient interaction, which nobody else does. This is the only place where you can get this, where you can talk one-on-one with patients or normal people that have some similar symptoms. So I'm really looking forward to that. I'm looking forward to really just the nitty-gritty, meeting people that could potentially be patients or colleagues, and kind of the networking there. I think it's really neat.
Dr. Chung, what are you looking forward to about the summit this year?
Well, at least I got to meet Rachael, if she's there.
I will be.
Dr. Orbuch, you are joining us again. What are you looking forward to the most?
I like the practical, functional approach of the conference. It's really, it's less theoretical and more really things that you can apply to your own practice, and it's nice to interact with colleagues on the healthcare side, and also, like you said, with patients, and you really get different sorts of feedback, and you make connect with new people. I think it's a very well-run program usually. Thank you, Sally. And
never know.
Sally works so diligently, and she's like a worker bee, even all year long. So that's my.
So the very first summit, there's always like a week of panic. So randomly, the Dr. Orbuch called when we had the first summit in the week of panic. I think you called multiple times. And it ended up that, I have to worry about all these things. I have to feed people. We feed you breakfast and lunch. We have to be able to pay for that. And I was like panicking. And when he got to the summit, he looked at me and he said, "Don't worry. I have a peanut butter jelly sandwich with me. You don't have to worry. Just give my food to somebody else." Do you remember that?
I do.
Yeah. I do, because, we all our community is small, and we all try to take care of each other. Dr. Joe, you are headed to Margaritaville to join us for the Endometriosis Summit. What are you looking forward to aside from those 4 CME?
Well, I mean, honestly, this is, I've been to every one of them, and they get better and better. The meeting is great because you have the doctors, you have the patients who are, telling their stories. And also, I have to tell you, afterwards, it's a lot of fun, and the meeting's over. Everybody really has a nice time together. And it's a really good camaraderie. I love it.
Yes.
Yeah, I spent the morning coming up with our camaraderie activities. And we'll have to wait till next year, but they offered me a Polynesian fire show. It just doesn't go
Whoa.
with our theme. So we're gonna have to do that one next year, but they wanted to, we can do things like trivia and tie-dyed pacing. It's like Club Med at Margaritaville. It was really cool, all the things they offered. So I will see you March 8th through the 10th. We will be back here. I think next week is bladder. I have to look on Mondays at 8 p.m. If you just, everybody, we're going to go around, just give your handles on how to be reached. Dr. Haverland, how can people reach you?
So I have an Instagram, Texas Endosurgeon. Also, I don't know phone numbers and such, but
No, just the handle is good. Dr. Orbuch, what's your handle that people can reach you at?
So my Instagram is at Dr. Larry Orbuch, Dr. Larry Orbuch, and I'll send you my other info.
Excellent, please do. Dr. Chung, if people want to chat with you, how can they reach you?
On Facebook, you'll find me. Absolutely.
On Facebook, excellent. And
Yeah.
Dr. Raccuia, are you going to send people through the king himself? Or are people going to reach out to Dr. Vidali to reach you?
Yeah, I think so. I think it's always been like that. So I kind of like stay back a little bit. And but if anybody wants to talk to me, of course, that can be arranged.
Yes. Go ahead, Dr. Chung.
I have a question for you, Joe.
Yeah.
This is a real case, a 30-some-year-old patient that she had this pain forever, ever since she has the hernia plug. And myofascial pain, pudendal nerve, bladder pain, urgency, frequency. And what's your thought of removing that plug,
Removing the what? I'm sorry, I didn't hear
the
you.
hernia plug?
Oh, I mean, she has a hernia.
She had a hernia repair.
Yeah.
The plug was in.
Yeah, let me tell you
Smash.
something. Having
It
pulled
sits
out,
right there, and I just wanted to yank it
Right.
out because I just could not figure out that pain.
yeah, can I tell you something? You got an MRI. Okay, and is a nerve involved with the plug?
Well, I think the plug sits probably right on the genitofemoral nerve. I was so attempt to cut that nerve.
Honestly, I've done, many, unfortunately, I will say this, unfortunately, I've done many of those, unfortunately, during the years. It is very difficult. Also, you have to realize most of these meshes they place are plastic. And at the end of the day, you're going to have this wad of horrible adhesions. Having said that, to answer you, absolutely, I would take it out, because the plug is what's probably causing most of the problems.
Right.
The surgery becomes a little bit, it's not like, oh, the plug is maybe 1.5 centimeters and you think it's a little thing, but it becomes a very entailed thing in terms of.
I'll send it to you, New York.
There are great videos, Dr. Chung. We do have hernia night, but there are great videos on she's called Hernia Doc, herniadoc.com, and on YouTube, she has surgical videos of those surgeries, and they sort of like instantly get away from you because they're sort of very involved. If you want to check her out, Dr. Toph, I think Dr. Orbuch works with Dr.
Would you
Toph.
do
Yeah.
Inguinal nerve, hypogastric, and genitofemoral nerve neurectomy?
We got to have her one year. She's so fascinating.
I'll leave you with one quick case that was very interesting. I had a patient in her 30s with 3 prior surgeries, incompletely treated. She then had a hysterectomy by a GYN oncologist who told her that was going to treat a disease. She was like in her mid-30s, walking with a cane. And
I have seen that.
And I operated on her. She had a golf ball sized nodule of endo that was embedded into the obturator foramen. So I had to do a massive dissection to get this thing out. And I went to see her in between cases that afternoon to see how she was doing in the recovery room. And the nurse said, "Oh, she's in the bathroom. If you wait a minute, she'll be right out." So she walks out of the bathroom. She's walking toward me with this big smile on her face. And I'm looking at her smiling. I'm like, why is she smiling at me? And she's like, "Don't you see? I'm not walking with my cane anymore." She had a limp and she was walking with a cane. She goes, "That pain is gone." So it's just really, it can be so dramatic, and things like that really open your eyes to what the possibilities are.
And Dr. Chung, I'm gonna add one thing too, that area was injected already. Did you inject that?
I
patient?
did. I did inject the inguinal. But see, the thing is that plug is right on the path on the muscles, so that's why I worry about that has some restriction. Just like Sally was saying, that myofascial pain restriction and causing a lot of those pain. So, and I
I
have
would
done,
add, did you could have, if you think it's like, as for, not to hijack the whole live, but if you can sort of access that musculature through the hip. And if you have a really good manual hip PT, they may be able to mobilize to get the muscles to relax so that you can get into the nerve a little better to inject. You know what I mean? I could show you exactly what you do when we get down to Orlando.
Can I make one last comment to you, Dr. Chung? One of the things that we have patients with neuromas after hernia surgery, what we've done is we give them 1 or 2 injections. What that does is, if the injections work, that means you got to take it out, okay? Because it's not going to be a prolonged period of time where you're going to be pain-free. And it sounds to me like that type of surgery for the patient described might be indicated. And it's a pain in the neck to do, but it's doable. And you might actually be providing this patient a really good service.
I guess I'm just trying to figure out this plug that's right there, and I see it, but the extent of it, I don't know how far it would go all the way up the inguinal canal.
Well, I can tell you this, when there's a plug with a hernia repair, there's 2 meshes, right? What happens was, and maybe people overuse plugs, but that's another topic. What happens is you have, once you open up the inguinal canal, a plug is placed, and it looks like an umbrella, and that's kind of just shoved down there, quite honestly. Then you place a mesh over that, and you do the repair to the tendon and the conjoint tendon and the ligament. The plug at that point is almost irrespective of that mesh that's placed on top. So what you're seeing is like the underside of a hernia repair. And I will almost guarantee you, from what you described, that patient probably will benefit from, getting the plug removed.
All right, we got to wrap it up. Actually, I always want to do more hernia content when I start speaking to the hernia surgeon again. And we will be back at you next Monday night. Good night, everybody.
Good night.
Thank you very
everyone.
much.
Thank
Bye-bye.
you.
Thank you. Bye-bye.